Okay, just while Katie is getting sorted, we will just take a sec. What we're going to do for the next hour and 15 minutes is go back and deliberate again on the questions related to comparative clinical effectiveness before we take a series of votes, and as we take a series of votes, and then do the same for potential other benefits, and ultimately a vote on long-term value for money. So this includes a lot of touching base on some of the evidence, quote unquote, we heard from the clinical trials earlier today. It will certainly discuss a lot of the testimony and other perspectives that are in the report and that we benefited from greatly today by the patients who came, and we want to thank you again for coming and for being part of this meeting. Those perspectives are always central to the way that the conversations and the thinking proceeds. So the first thing we're going to do, though, is before I even take it further, we're going to make sure that the CEPAC has their voting system set up. So to do that, we have a test question, and I usually invite one of our staff to lead them through a question that has taken we take great lengths to make sure that these questions are true, and hopefully they are interesting. So, Michelle?
Thank you, Steve. Is everybody set up on the voting software and ready to go?
Okay, good. Thanks.
Great. All right. So we will take the test question. What is the official state snack of Illinois? Hot dog, deep dish pizza, Frango mint chocolates, or popcorn? It looks like we have 11 out of 12 responses so far.
Frango?
Just waiting on one.
I'm familiar with Frango.
Actually, did I miscount?
You're good.
Oh, thank you, everyone. And the answer is, all right, 6 voted for deep dish pizza, but unfortunately popcorn was the answer. 4 of you got it right. And I'll hand it back off to Steve.
I think the distinction here.
We do offer we offer continuing medical education credits for people who get this question correct. This is the pre-post, so just remember popcorn and you'll get credit later on. Okay, so you're going to note as these questions go by that they sometimes shift perspective. We'll be doing different kinds of comparisons. And that's, again, with discussion with policymakers and our own thinking around how some of the votes can reflect some of the decisions that will be made downstream. So, again, to note that, this is the style of the questions that many of them will come in. Is the evidence adequate to demonstrate a net health benefit? And the first one will be with lasmiditan compared to no treatment. And I need to point out that the population, okay, we don't have that slide, sorry. The population for which this question is posed matches the label, which is adult patients with a diagnosis of migraine. Okay, so it does not stipulate prior attempts to treat with triptans or any other medication. All right, so first question, is the evidence adequate to demonstrate a positive net health benefit for treatment with lasmiditan compared with no treatment? So Steve, could you just again briefly summarize the evidence that we have for that and the rationale behind the ICER evidence rating?
Right. So in the evidence summary, this would be table 1, referring to population 1. So for lasmiditan, we've shown that compared to placebo, there were improved outcomes across all of the primary and secondary outcomes, as well as mild to moderate side effects as described. So for lasmiditan versus no treatment, ICER rated this as a B+.
Okay. Any questions from the CEPAC? Yes, Bijan.
So this particular question is for, generic in the sense that irrespective of any population, but the one that the table 1 you were saying it's only for population 1, correct?
That's correct. So the comparison is with no treatment. So that would be equivalent to population 1 in our analyses.
Okay. Thank you.
Okay, I know there will be some questions. There will be more debate around the nature of the evidence.
That's correct.
If I don't, and again, I will turn to the patient and clinical experts certainly from a time. They will ask you questions. If you feel a burning urge to say something, I doubt this is the question around which you feel that. So why don't we go ahead and vote, and I will show the responses when they're complete. All right, 12 yes and 0 no. Okay, so keep that framing in mind. All patients, all adult patients with a diagnosis of migraine, is the evidence adequate to demonstrate a positive net health benefit for treatment with rimegapant compared with no treatment? Steve, again?
So again, this is Table 1, Population 1, rimegapant versus no treatment. We presented evidence to say that compared to placebo, rimegapant had improved outcomes for both primary and secondary outcomes, as well as having a low side effect profile and, at least in the open label studies, a very low discontinuation rate.
Anybody want to question, push back, ask for nuance? And if you do, well, you can jump right in. Otherwise, I'll look for your tents. But go ahead. Sure, Eric.
So I noticed that the odds ratios are smaller in this particular case, but this is a yes/no question in terms of comparison to placebo, if I read Table 7 correctly on the NNA.
So the odds ratio from the network meta-analysis you're referring to? Yeah, so the suggestion is that the question is the absolute odds ratios are less for benefit for rimegapant compared to the triptans, but the confidence intervals are such that it excludes this as being statistically insignificant. So these are significant in what would be considered clinically meaningful differences.
Thank you.
Yes, Reem.
But also keeping in mind that it appears that it has a better side effect profile than the first one, right? So the net benefit, we'll consider that.
Right. And you'll get your bite at the rimegapant, ubrogapant versus lasmiditan questions. Okay, so this one is, again, rimegapant versus no treatment for patients, all adult with migraine. Yes or no, please complete your votes. 12 yes and 0 no. All right, let's go to number 3, big shock. This is the same question, same population for ubrogapant compared with no treatment. Probably the same table, the same, not just a different row.
Right, so again, this is a B positive rating for ubrogapant. The data is very comparable to rimegapant in terms of the odds ratios compared to placebo. And again, ubrogapant was associated with a low incidence of side effects and also a very low discontinuation rate in the open label extension trials. The absolute relative risks were very comparable to rimegapant.
Okay. Looking for any questions? All right. Being none that I see, can you please complete your voting? 12 yes and 0 no. If life were this easy, all right? So let's keep going. Is the evidence adequate? Again, all adult patients with migraine. Is the evidence adequate to distinguish the net health benefit between the gapants, rimegapant and ubrogapant, the two of them? Steve?
So this is now Table 2 of the evidence report, and this is for all patients comparing rimegapant versus ubrogapant, and this is a C rating, meaning that they are comparable. This is based upon the data we presented showing that they have comparable efficacy as mentioned on the primary and secondary outcomes, and again, no difference in their comparisons in the network meta-analysis. This also held true for the side effect profile as mentioned between the two drugs. We had some mention of some additional analyses from ubrogapant that relates to the time period between 2 and 8 hours, as Dan discussed and as you all discussed earlier this morning. We don't have comparable data for Rimegepant, but given that they're working at the same receptor, it's difficult for us to say whether there's any difference in sort of their effects after 2 hours. They have similar 2-hour outcomes, and they also have similar 24 outcomes in terms of whether, if they had benefit at 2 hours, did that benefit persist at 24 hours? And those were also comparable between the two.
Clinical experts, I don't know if you have anything you want to add, but this will come up in the policy roundtable, but is there any reason that you see in the early evidence that we have at launch or around launch to distinguish the net health benefits between the two gepants? No? Okay. Yes, Stuart.
Just for clarification, it says, is the evidence adequate to distinguish the net health benefits, but it doesn't say distinguish a difference. I want to make sure which question you're asking.
Sorry, basically it's asking, is the evidence adequate to distinguish between them, i.e. one is better than the other? Okay, please go ahead and vote. All right, we continue to have unanimity. Let's move on. We don't need to do 4A. Okay, now, for all adults with migraine, the question reads, is the evidence adequate to demonstrate that the gepants, now that we've decided we can't distinguish them, we're just going to say the gepants, have a superior net health benefit compared to triptans? All right.
So this is now back to Table 1. This refers to population 2, which is patients who would be eligible to take triptans. And for this drug, we rated it as a C minus. As mentioned, the compared to, excuse me, lasmiditan compared to the triptans had somewhat lower efficacy. It was statistically significant for the primary outcomes and pain relief for lasmiditan versus elatriptan. The difference between lasmiditan and sumatriptan was of a similar magnitude, but was not statistically significant. So there's a little bit of difference between those two. That said, in terms of side effects, there was evidence that the triptans for both of them had fewer side effects than than for lasmiditan. So comparable or slightly worse benefit and more side effects, leading to a C minus rating.
Okay. Just want to be, sorry?
Did I?
I think we're on.
Did I?
No, he's right.
He's right.
He's right.
Okay.
I hope I'm one.
Yeah, this is the gepants versus the triptans. C minus.
Oh, I'm sorry, I was jumping, that's correct.
Sorry?
I
I
brought
thought you
in
were talking-
lasmiditan
oh, it's
as the.
True.
It's C minus for all.
It would be good to ask.
The let me correct myself. So what I said for the benefit was the same. In terms of side effects, the triptans were uniformly, had fewer side effects than lasmiditan.
Well, let's get to lasmiditan.
Then not lasmiditan, then
All right. So this is about gepants versus
the gepants.
triptans.
I keep going to number 6, I'm sorry.
Right. So do you want to state it one more time?
I'm glad that I'm not in your shoes. That the side effects comparing the triptans and the gepants were comparable.
Comparable. There we go. Got it. Okay. I just want to make clear, again, you're first.
I apologize.
After I make clear, this is not asking whether triptans are superior to gepants. This is not asking that. It's asking, is the evidence adequate to say that the gepants are superior to triptans among an all-comer population of adults with migraine? Sarah.
So you've touched on the nature of my question. I wanted to better understand the use of the word superior. It's the first time we've seen it introduced in a question. And I saw draft questions and superior wasn't in there. So I'm just trying to understand if this is a nuance based on anything that we should be aware of as we prepare to vote.
Thank you for asking, and unfortunately, this is I'll take responsibility for some editing that did not get consistently passed through. When we say net health benefit, we mean a positive or superior net health benefit. All of these words and the ways that the questions have been framed should mean the same thing. So when we were just voting previously, even though the word superior wasn't in there, I think I even said positive, because that's what it means. So we're asking here whether the GPANTs, not whether they do or not, whether the evidence is adequate to demonstrate at launch, which early evidence, do we have adequate evidence to demonstrate that they are superior in their net health benefit, which that means both benefits and harms, compared to triptans. All right, yes, Katie.
I would just like to drive home.
Sorry, make sure you get close to that if you can.
Yes. Sorry. I would just like to drive home, as you're thinking about this question, that triptans, we haven't really gone into all of the side effects, even for those who don't have cardiovascular risk factors, that the side effect profile for triptans is incredibly superior to the, this one is on GPANTs, yes. So, sorry if I'm not making sense. Sorry if I'm not making sense. I just got really dizzy and I have a migraine attack coming on. So I'm going to take some medicine here in a minute, but so if I didn't say anything correctly, please ask me to clarify. Or
It was fine.
We will, thank you. Let me go to Chris and Jeff, and then Eric, if your question or comment's connected, but Chris and Jeff?
So, I mean, what this entire process is, I think, fascinating and challenging and impressive. I think the fact that you are taking on this challenge of trying to make a balanced assessment of a new intervention and all of the things that entails, and how can you accurately predict the performance of a new intervention, that's a really daunting task. And I think this question, for me, sort of highlights some of those subtleties, namely, superiority we're used to in certain isolated contexts. If you narrow down to the best evidence that we have here, the most consistent measure, the 2-hour pain-free response, et cetera, you can make an assessment, fine. But the fact, I think, that this question includes something like net health benefit immediately then opens the door to you're trying to put that in the context of other considerations, side effects for sure. But I can tell you as a practitioner, that's a bigger web than just side effects versus benefits. We live in a world where every single day, we live in a country where every single day these patients are prescribed the least effective and often most harmful drugs that they could possibly be prescribed. So they are given narcotics, they are given Fioricet in its various formulations, which we have proven over and over again are the worst imaginable choices. Why is that? I think it has something to do with the fact that for patients, what drives refills is mostly about efficacy, even at the cost of certain side effects. I can tell you that I prescribe what I consider the most effective treatments every day, which have more side effects, and patients come back and say, I'll do that, because it actually worked. But for doctors, it is clearly true that side effects and apprehensions about those drive decision-making, consciously or not, more or at least as much as efficacy. And that, I think, is where this question becomes subtle. We know that if you compare all the oral triptans to the injectable formulations, there is no comparison. You're talking about a 20 to 30% chance of success or a 60 to 70 chance of success. Tell me another disease in which a doctor faced with those numbers would say, you know what, I'm going to go with the less effective option. But we do it every single day here. 95% of prescriptions are for oral triptans. I think that's saying something about both, I'm afraid of the side effects, I'm afraid of the risk to me and my license because of these cardiovascular complications, et cetera. It's a disease that shouldn't really need treatment with something as aggressive as an injection. There's all kinds of memes there. But the bottom line is, given a choice, people go with the lower efficacy option or the worst options because of something to do with their fear of side effects and mechanism. The most important thing to me about these new classes of drugs is that we can finally say to all prescribers everywhere, in every context, you have a safe and effective option for treating these attacks. And I am quite certain that that's going to make a very large difference in the way people think about their prescribing options, because it's not simply prescription or not, or good or bad, it's, oh, I don't have to worry. And I think that that's something to factor into the concept of net health benefit that has really big implications.
Thank you. Jeff?
I kind of agree. To some extent, people may not prescribe the most effective medication, but I think some of the fear is misplaced. I got a call yesterday as I was getting ready to go from a 70-year-old woman, extremely effectively controlled with triptans her entire life, been very happy with it. But she's now 70 and she's developed some well-controlled hypertension, and her doctor said, well, you really shouldn't be taking a triptan. Well, it's just nonsense. It's just nonsense. Clearly this is there's always a risk-benefit analysis. So the answer is I can put out what I say to my medical students, what's the best answer in medicine? It depends. And it depends in this case about that. There is certainly a population, because we've heard about all the bad things that happen with triptans, and I'm not disagreeing. I have people I can't use them. Some people are very well controlled. So just to realize that people are not uniform, and you can't just say triptans are really bad. I remember when triptans came out, it was a godsend. I also remember when triptans came out and we sent everybody to the emergency room for their first dose because we didn't know what their cardiovascular risk was going to be. So I think if we get to this point where we individualize care, totally agree, people get narcotics as opposed to triptans, and the safety thing there is just not a comparison, but there is fear. But if you're thinking about it as a general thing, there's certainly populations that do well with triptans, there's populations that don't do well, and I think what we're asking in this question is to say if you take all comers, the group that does well, the group that doesn't do well, the group that can take it, the group that can't take it, is there a net health benefit? So I'm going to agree with Dr. Gottschalk. It's not an easy question, but keep in mind there's lots of people that do fantastic on triptans. Actually, they're underprescribed. I get referrals for people for prevention medicine, and I say, well, what do you take when you get an acute headache? And they say, well, I take Tylenol. I'm like, and does it work? Well, no. Well, did anybody ever give you a triptan? Well, no. Why are you sending them to me other than get them out of your panel?
All right. Katie has a comment, and then Eric, you had a comment too. Does it need to?
Oh no, this is
Okay.
just very quickly that for patients, I agree with both of you fine gentlemen. I just want to make it kind of clear that patients who are in pain, if an oral medication works for them, that's great. But we're not afraid to take a shot. We're not afraid. I think I just don't want that to be, whether we're talking about triptans, whether we're talking about CGRP inhibitors, whether we're talking about something that, I know all of these are in pill form, but down the road, let's not let that be it. I ask that you not put that into consideration, whether or not a patient is willing to inject themselves. These things are so easy to use. They burn for a few seconds, and they're more, the efficacy rates are higher. So it's just, when we're in pain, I don't care that I've got to go give a shot to myself.
Understood and well said. Eric?
The only thing I was going to add is that I wanted to bring forward some of the patient comments and voice that we heard previously that I took away from the last panel. In this particular case, a vote of no, right, that I don't see a superior net health benefit does not mean in any way that an ineffective triptan should continue to be used on a patient who it's not working for. And I think that's I don't want this question, to get misconstrued, or the answer to this question to get misconstrued that way, that right. We're saying, oh, you should continue using an ineffective treatment that's known to be ineffective for a particular patient. So I think that's well covered by the other comments, but I think we heard that loud and clear from the patients.
Totally agree. Well said. David?
Yeah, I completely agree with that. I just wanted to, we went down sort of an oddish path because of the injectable triptans, and it's important to know, even though it doesn't say this in this question, that our report looked at oral triptans because we were looking at other oral acute therapies, and although it doesn't say it, this really should be compared to oral triptans. That's what was being asked.
No, and I just raised the difference between oral and injectable to make the point about in the real world, the behavior of prescribers indicates that efficacy is not apparently the biggest driver of their choices. And that in the context of these data, we're looking at the primary outcome being pain freedom in 2 hours, great. But when you take into context this understanding of mechanism and risk, that's a very different calculation.
Okay. Any questions or further comments from CEPAC? All right, Greg?
My reading of the question is that the focus is on the evidence and whether the evidence is adequate, and that's how I'm going to answer the question.
Okay. All right, let's go ahead. Oops, sorry. Okay. Let's go ahead and vote, please. Is the evidence adequate? Again, all adults with migraine to demonstrate that gepants have a superior net health benefit compared to triptans. Okay, 12 no, 0 yes. All right, number 6, you can guess, is the same question, but with lasmiditan. Is the evidence adequate to demonstrate that lasmiditan has a superior net health benefit compared to triptans? Steve?
All right, so this is also Table 1, Population 2, lasmiditan versus the triptans. The evidence rating is a C-. This is based upon evidence presented that lasmiditan was slightly inferior to the triptans in terms of efficacy. There was as I mentioned incorrectly in the last one, there was a difference between sumatriptan and elatriptan, where elatriptan was superior in efficacy to lasmiditan. Sumatriptan, the confidence interval included the possibility that it was not. In terms of side effects, both of the triptans in the trials had fewer reported adverse events than lasmiditan, and so that led to a C- rating.
Okay. I think many of the comments that were made with the previous question pertain to this one equally. Are there any other questions or comments related to lasmiditan's comparison to the triptans? All right, please go ahead and vote. Oh, I'm sorry, Katie.
Nope, I'm sorry, I didn't.
Yes, what's wrong with you? Don't use your tent card. Just kick. You're right next to me. Just kick me. Just kick me.
You all heard that. Just kidding. No, thank you. Very quickly, I'm disappointed that in how the last vote came out. I understand, but as the gentleman said a few minutes ago, I'm sorry, I can't see your name tag. I'm so sorry. You said.
I think Gregory.
Yeah, thank you. You said the question is based on the evidence. That's how I will vote. And I just want to point out that I believe many people on the voting panel and obviously some on the round table found many flaws in the model. So some of the evidence that came out of the model was flawed. And so I'll just say that. I just want you to take that into consideration.
And just to reassure you a little bit, or maybe it won't reassure you, the model questions are coming at the end. This one actually doesn't deal with the model.
It's about
This
the
is
evidence.
comparing the clinical trial data.
Okay,
And there were some
thank
issues
you.
raised about 30 years ago versus today and some other things that I think got a hearing, but just to let you know.
Thank you. I appreciate that.
So keep your powder dry. Any other questions? Okay, please go ahead and vote. All right. One last comparative clinical effectiveness question. Now it's gepants versus lasmiditan. For all adults with migraine, is the evidence adequate to distinguish, that means one better than the other, the net health benefits between the gepants since we've decided that they're essentially indistinguishable, and lasmiditan. Gepants versus lasmiditan. Steve?
All right, so this is back to table 2. If one is comparing rimegepant and ubrogepant to lasmiditan, we rated that as a C plus, as comparable or more effective. If you flip it the other way, lasmiditan versus a gepants, it would then be a C minus. As mentioned, there is no direct head-to-head comparison data, so this is indirect evidence from the network meta-analysis showing that the effectiveness between lasmiditan and the gepants were comparable. There is odds ratios that say that lasmiditan may be slightly better in terms of benefit, though those intervals include one being that they're not statistically significant. In terms of harms, the evidence is that the gepants had fewer side effects. We should say that the side effects overall for all 3 of the drugs was mild to moderate, though the adverse events reported were fewer with the gepants than lasmiditan, and in the open label studies that are available, significantly fewer patients discontinued therapy over the course of the trials, the open label trials, with the gepants versus lasmiditan.
All right. So just again, conceptually, if you can imagine what we tend to think of when we're saying C plus and C minus, C means about the same. C plus means we think it's about the same or better. C minus means about the same or worse. And you can kind of think of it almost as overlapping confidence intervals. So that's the way it kind of looks in our heads when we say C plus and C minus. And I think you heard from Steve Atlas the evidence behind that thinking. Comments from clinical experts or questions from the CEPAC? Eric?
So
Sure.
I'm interested in the discontinuation, right, as a indicator of effectiveness. So this is a medication that if it works, people stick with it, and if it doesn't, people don't. I don't want to overweigh this particular dimension of the evidence in this particular case of saying that there might be an ability to distinguish between the two, but I would love for my clinical experts or others or patients to comment on this particular attribute.
Well, I mean, so you've got a little bit of indirect information that maybe it's a little bit more effective. I mean, how many qualifiers were in there?
There were 3.
Yeah, yeah, and then you've got, we know there's significantly more side effects. That's pretty clear. There's a fairly high rate of dizziness. Now, fairly high rate of dizziness doesn't mean everybody gets dizzy. It means 80 or 90% of people don't get dizzy. But you have to balance, I think, in that case, just like with any medication. Well, maybe it's more effective, but I'm going to have to get more phone calls about dizziness and side effects and what's the risk and so on. I think that's the case here. I'm not, having looked at the evidence, I haven't prescribed any of these yet, but having looked at the evidence, I'm thinking, maybe there's a little higher efficacy rate, but everybody's individual. And would I be more likely to try one versus the other? Well, it depends on the side effects and it depends on a lot of factors. So that'd be the way I would look at this.
I agree. I mean, I think the additional dimension there, or the other way to say that, is that this is a spectrum, and there will undoubtedly be people for whom lasmiditan is an excellent choice and not much of a problem, and there will be plenty for whom there's a fairly equal balance there that makes it hard to choose, or clearly in the negative, and the same may go for the gepants, though I think it's fair to say that the clear evidence that there is a higher rate of side effects suggests that there will be more problems with lasmiditan because of that, and that there will be a more select group of people for whom that balance, that trade-off makes sense. But how to factor in the suggestion that there may be a slightly higher efficacy there is tough.
With the discontinuation rates and let's say the difference in the discontinuation rates that we've observed in controlled trials, right? is that sufficient to influence the decision about which of these two products to choose first? In your case, I mean, you don't know, so you
Hold that for the policy
Yes,
roundtable,
sir.
just because which you would use first is not necessarily related to this voting question. Believe it or not.
It has to be, well, to be honest, it has to do with whether or not I can, if I can distinguish the net health benefit, it has everything to do with which one a clinician
Could
might
be.
choose first.
Although there might be potential other benefits or other contextual things that would weigh into that. So just to give that sign. Okay, why don't we go ahead and finish the voting on this, please? Is the evidence adequate to distinguish between the two? 11 no, and 1 yes. Just for the record, every once in a while, someone hits the wrong button, but if that one yes
hit the
was
right button.
Was it really yes? There you go. We cherish our anonymity and the courage to break it. All right, let's go forward. What we're going to vote now is on something very different and a very different patient group. And we did this because we thought if we're going to talk about potential other benefits and the contextual issues, it makes more sense not to follow the FDA labels, but to follow where you might find more potential other benefits and contextual issues weighing into judgments of value. And also, as we'll talk about at the roundtable, the general consensus that these drugs will be used among patients who have tried triptans already. So we're now asking you about patients who have migraine for whom triptans have not been effective, are not tolerated, or are contraindicated. And we will actually talk about almost every single one of those terms in the policy roundtable because it'll be part of insurance coverage considerations. But let's think about them as a group now. So, does treating those patients with gepants offer one or more of the following potential other benefits compared to over-the-counter therapies? Because at that point, let's assume that they've tried everything else and it's basically the gepants versus what they could do for themselves. So there are 4 of them, and the goal will be to vote on as many of these that you think are potentially important enough for decision makers to consider when they are sitting down to think about price, about coverage, about clinical use. A, the intervention, both gepants, will significantly reduce caregiver or broader family burden. B, this intervention offers a novel mechanism of action or approach that will allow successful treatment of many patients for whom other available treatments have failed. C, this intervention will have a significant impact on improving patients' ability to return to work and or their overall productivity. And D, there are other important benefits or disadvantages that should have an important role in judgments of the value of this intervention. And we can identify those. Sometimes we vote on them, sometimes we just accept them by acclamation. So that's the set, 3 plus an open blank. Some of this has definitely come up in the conversation and the testimony from patients and from others. Let's talk about questions around this, and we definitely want to get the views of the clinical experts and patients in particular here. Rachel, I'll start with you.
Sure. So I do think it's relevant that this is a condition that primarily is affecting women, at least in the clinical trials that we've seen. And so we heard in the modified societal analysis that there are labor benefits that are taken into consideration, but we heard, I think, quite movingly from Eileen and Jamie about the challenges of caring for children with this. And also I'd add that a lot of these women are in an age group where they might be caring for older aging parents as well. And so I think there's an element of this that is incorporated into A, which is caregiving for a broader family burden, but there's also this additional factor I think is important that we are primarily serving a population which might be underserved, particularly women.
Gee, Sarah, does that sound like something you've heard of
Well
before?
said, and thank you for bringing up those considerations. I mean, we could spend a lot of time talking about the role of women. Women make up 52% of the total population. Women assume many different roles. They are caregivers, they're parents, they're daughters. They make the majority of the healthcare decisions in the family. So women have a huge burden in general, and as we've discussed, they are predisposed to this debilitating disease.
So I'm going to consider the option of and asking if it should be by acclamation or vote, but what I think I heard Rachel say specifically was that this all fits in some ways to A, much of this, but that there's another factor, which is that women have been in some ways, and maybe many ways, maybe always, an underserved or underappreciated or undertreated population in the United States. So that there's an effect, in a sense, on a disparity, an historical disparity, not just the burden of illness within the female population, but a historical factor to this as well. If we're willing to kind of figure out a better way to word that than that long string of words and accept it by acclamation in our report to highlight for policymakers, can I just see a show of hands? Is the CPAC okay with that, or do you want to talk about it further? Okay. Sarah, we may even look to you for some guidance on the language. Okay, good start. Other ideas on how you want policymakers to hear what's important outside the clinical evidence? Katie.
To Sarah and Rachel's points, I think that we should also think about adding diversity in not just male, female, but ethnicity and race and diversity, because they are very underserved in the migraine population. So I would just add that. And then going to D, I would, two things that came to my mind to fill in the blank. There are other important benefits or disadvantages that would have an important role in judgment. Other disadvantages of not treating your migraine disease is potential leading to chronification, or you're not doing it consistently, or I now have comorbidities that I never had before, and so I think that those comorbidities and chronification are disadvantages, and so I'm sorry.
No, what I'm hearing is that there may be, sometimes we talk about these as being the non-health things, but you're saying that there could even be obviously other health effects, especially for the worst end of the spectrum affected by migraine, where you wouldn't pick that up in a clinical trial either, obviously. Right. Is that fair?
Yes, because most of us who are that have those can't participate.
I think that, again, I guess my prerogative here, I'd suggest that's also an important perspective. Again, this is kind of true in many chronic conditions, that the more severely affected disappear in terms of people's general view, especially if it's a big population. They think they know that the norm is the norm. But people who are more severely affected potentially can gain significant other benefits that people should be aware of.
Right.
So I think we can figure out a way to say that here too.
Right.
Okay. Is that okay, CPAC? We'll weave that into the record? Again, with much more succinct language than I just used.
Or that I just used.
No, you were good. You were good. Okay. Reem.
So two other, I think, important additional benefits here is something that we heard from the patients, which relates to the hope and the fact that they have other options, which would be important to highlight, given that triptans, were the last kind of new thing in this field. So we've had them for so many years, and this is the first time there's a new option. That's important. But I also think we should highlight the importance, which was mentioned multiple times, about opiate use. So that 15% or 17% of headache being treated with opiate is a real problem. And that affects everybody. Definitely affects the underserved and a diverse population. So having some, maybe some attention that there are newer options, hopefully will help decrease the number of people who will receive opiate for treatment of headache. And not to say that some patients will not benefit, but I think that needs to be highlighted.
Okay. I think, again, because the voting structure makes it hard to vote on a D, a lot of this time we'll just kind of do it I think, again, we're talking about potential other benefits because part of the factor is that not all of these can be evaluated through evidence, certainly not at launch. But the fact that it seems likely that there's a potential benefit, there's likely going to be some effect on reducing some patients' need for opiates, and that's a good thing. Don. And then Steve, and then I'm going to try to wrap this up because we've got to do the same thing for lasmiditan, and then we've got important contextual issues.
I just wanted to add in that women also are proportionately the majority of the workforce too. So just wanted to be sure of that. But Steve, relative to B, and then follow on to C, is you got the word some in there, and I'm sorry, many, and I suppose many could be proportionate or it could be numerical.
Let me make it easy for you. This is 100%. I mean, in a way, this is a standard question, but we've framed the patient group as one for whom, for all of them, this offers a potential benefit because it's a novel mechanism of action. It's not another triptan, and so it offers a different mechanism that has a chance, I think. Now, again, maybe there are data of the patients who had tried and failed, the triptans had failed them in the trial so that we could decide that what % of those patients benefited from gepants. Do we have any idea of that from the data from the study, Steve? So we didn't get stratified data on patients who had tried triptans and were unsuccessfully treated and their reaction to gepants, just to say literally on a % basis, how many of them got some benefit?
So, I mean, in all the trials, there were patients who were triptan naive,
right.
And there were patients who had tried and failed or had contraindications or had intolerability. There was some evidence that there may be a slightly greater benefit in the population who had been triptan exposed to the triptan naive. However, those differences were not statistically significant, and so we did not consider them in our model. It's something that may be for future research, but it's but at the present time, it appeared that the drugs were, we would say, equally effective in both groups.
Okay. I don't like to guide you guys in your votes, but you should vote yes on B.
And the follow-on question in C is it intentional that there isn't a many before patients?
I'm sorry,
in
intentional
C,
what?
improving many patients as opposed to improving patients is.
I guess again that's literally you're pointing out some an inconsistency. This is viewed over all patients treated, so you could say on average it will, or there'll be enough patients who receive a big change to their productivity. I'll leave that to your discretion.
The side effect.
All right.
The side effect profile is less, so that's a point that you could make in trying to figure out your answer on that one.
Steve, I don't know if you saw Aaron has.
Oh, I'm sorry. I didn't. Aaron.
I just think as we talk about that there could be a potential reduction in disparities, we have to stress over and over again its potential, especially as we're talking to policymakers. Approving a new drug does not fix structural racism or sexism, and many of the issues that have prevented or created those disparities to begin with will still exist. And so, yes, more options potentially could help that, but won't. It's necessary, but not sufficient.
Right.
I would like to counter that. Today here, we're not talking about getting FDA approval. These 2 of the 3 medications are FDA approved. And so this is in the diversity and inclusion piece of this. That's really insurance companies who are in medical deserts and patients really don't have access to an ER or an urgent care. They have to somebody has to drive them half an hour to an hour. And so I think this is more of a policy question than an FDA approval issue.
Good. Okay, I'm going to try to shepherd our time so we have adequate time to talk about the long-term for value question, which will get us back to the model. So I'd like to close this now, Steve, if that's okay, and go ahead and vote on this. Now, again, you're going to vote for A, B. There's not going to be any vote on D because we've accepted several by acclamation. So your votes will be on A, B, and/or C. Vote for as many as apply. And because of the voting system, I won't know when you're done until you are done and you look up at me. That's the way I'm going to know when you're done. Okay, everybody looks done? Okay. 11, yes, A. 12, yes, B. 11, yes, C. And 5 to reinforce the acclamation for what we were talking about. Okay, let's keep going. Essentially unanimity on these potential other benefits. Okay, the same thing for lasmiditan. All right? So I don't think we'll probably need the same degree of discussion. It's really beyond its clinical effect. Does it also, you all voted essentially unanimously on A, B, and C. We'll say the same by acclamation effects on opioids and historical underserved aspects of the female population. And so I'm going to suggest for time, David, did you want to add something? Go ahead.
I was just going to suggest that on C, on lasmiditan.
Oh, that's right. Go ahead.
I would at least question whether a drug that has a warning that says you can't drive once you've taken it is likely to improve patients' ability to work. I'm at least less sure about that than with the GMAS.
I guess it depends on everybody's balance of if it detracts productivity on that day, does it still add to it through effective treatment in the day or days ahead? There'll be some balance there in some way that we don't know. There's no evidence on this, so this is, in a sense, a call that you'll have to make. Stacy.
Can you just clarify, though, for the side effect of the dizziness, that was in 20% of people that were taking lasmiditan? Is that correct?
Not much. I don't think it was that high.
No, 13% dropped out, and that's for any reason. It could be effectiveness or side effects in the open label extension. In the trials, I think dizziness was the highest, and that was, I think, in the 12 to 16% range. The others were less than that.
Great, thanks.
Okay, please, Stuart, I'm sorry, go ahead.
Can someone speak to how unique the 1F, 5-HT1F is compared to the other triptan targets?
The main important distinction appears to be that despite the fact that it is still a serotonin agonist, that it is devoid of the vasoconstrictive properties historically associated with triptans. So in that way, yes.
All right, please go ahead and vote. A, B, and/or C. Potential other benefits. And the same thing when you're done, you can just look up at me, that way I'll know you're done. I have everybody except Bijan still voting. Okay, and the results are 10, 11, 9, and 4. We have a recalcitrant 4 people who still want to accentuate an acclamation vote. Okay, well, we're doing so far better than the United States Senate. Let's keep going. Come on, you didn't think we were going to...
We have higher expectations here at the Midwest CEPAC, to let you know.
Thank you, Chair Roberts. Yes. I've been staving that all day long. Okay, so now we're going to talk about a real, hopefully quick, but an important one, because when P&T committees around the country start to meet, they are going to be talking not just about the gepants versus triptans and lasmiditan versus triptans. They'll want to know whether there's something special or other about them compared to each other as treatments that might come after triptans. Yes?
But the form we're filling out doesn't have this question.
Oh, okay. Well, we'll get to that later then. Sorry about that.
No, but I know the form like we're supposed to turn.
I think it's on, yeah, I know what you mean. But it should, the voting structure should be there for you. So this is just to talk about, we decided to focus this on the 2 we thought, well, one is still an open other, but we thought that you might want to talk about whether there's enough of a difference in the reduced complexity or something else that will significantly improve patient outcomes if you were comparing, if you had literally to pick, and this starts to get a little bit into your question, Eric, if you were going to pick one or the other first, and everything else, price and everything else was not an issue. Are there other benefits outside the clinical evidence that would identify a particular other benefit for the gepants or for lasmiditan. So please don't forget that B could be anything in either direction. So just real quickly, maybe one of the clinical experts or both, do you think in terms of potential other benefits, what should payers and others be aware of, if anything, to take into consideration when they are weighing the overall usefulness of lasmiditan and the gepants?
So I think the answer is certainly yes, but to the first one at least, but it relates to that point I made before about the very important feature here that the gepants in particular, are going to be a class of drugs that clinicians will now understand as both safe and effective specifically for the treatment of acute migraine, which is very different from what they have been, the concept they've been operating under for 20 years when it comes to the triptans. So that the fact that they are, proven effective in this same neurovascular system, but don't have that associated risk. And I do think it's relevant that, on the other hand, lasmiditan, although it is different and the data are clear, is similar sounding enough. It's a 5-HT1 something. And I think that will have a role in the perception that many clinicians have that it's more triptan-like than the gepants. And I think that those considerations will play a role in the tendency to choose this class over the other, or even for patients in thinking about which was more likely to be helpful based on their prior experience. I think all of those play a role in the conceptualization of the relative value of these two different groups.
So is there a devil's advocate argument here that, as I understand it, the clinical trials excluded patients with cardiovascular disease?
I wanted to comment on that. It's not entirely true. So the trials were structured to include people who could have a history of cardiovascular disease and even events. And for some of the criteria were a little different, but for several of them, it was simply that they had not had an acute major event within, say, 6 months. So those criteria are very different from what had been true for the triptan trials.
Jeff, go ahead.
To me, this gets a lot to David's point, which is if you can't drive after taking the drug, that's a big deal. And whether or not you believe that, if that's the current recommendation, it's going to have a big effect. I mean, if we're part of the advantage to treating somebody, take this pill and you can carry on with your life, and instead it's take this pill and you have to stay home, that's a big factor. And whether or not it's true, it's going to have a big impact on people's ability to think about prescribing it.
Okay. Again, partly for time, and I apologize. So remember, we're going gepants offering something compared to lasmiditan. So A was written in the way that gepants, because reduced complexity, meaning you don't have to worry about the driving, significantly improve patient outcomes. It's not a perfect fit, but I think that's part of what we were trying to capture. The B, and I'm trying to channel, Chris, what you said, is that at least some, maybe many clinicians will feel that the safety profile, the presumed and so far safety profile of the gepants, even if you're looking at nets, it offers a distinct clinical profile that offers a potential benefit from the view of clinicians. Yes,
I
Aaron.
may be making this more complex, but it sounds like then we're
Sorry,
saying
can you grab
both.
your microphone?
Sorry,
We can't hear you.
I feel like we're saying both A and B then are just that because it has significantly different side effects, and in the sense, one's just looking at the patient and the other's looking at the clinician.
Well, for me, there's a difference between considering stated or listed side effects and their rates and this perception of safety based on mechanism. So that the fact that with triptans, even at the time of the release of the drugs, there was no actual data saying 5% of these patients dropped dead of a heart attack, but the fact that they were released with the understanding that they worked by being vasoconstrictors and therefore should be understood as risky has had an enormous impact on the rates of prescribing and the hesitation among certainly primary care clinicians about whether they can even consider those drugs. So in that sense, there's to me an important distinction between one drug has a much louder signal of important side effects in the trial, But then this other component of, am I comfortable just prescribing this drug routinely based on how it works?
And you see that as a difference between the Japans and lasmiditan?
I think there's a component of that even here because of that both side effect statement and that it's more similar to triptans than Gepants. I think there's an element of that.
To a certain extent, this will be fought out in the trenches of the drug detail world and practicing clinicians. And I guess what we're signaling to payers and to others is that clinicians will be thinking, whether it's based on evidence that people will all subscribe to or not, that there will be an influence in the clinical expert world that may come into play when they are reacting to coverage policy that might treat lasmiditan and Gepants as equivalent, that they would potentially view this as something else that should be weighed. Is that a fair statement?
Absolutely.
Okay. A is actually kind of a bad way to capture the dizziness and the fact that you can't drive afterwards, because that's really just a side effect. It's not complexity per se. So I'm going to suggest, again, we were trying to rewrite this late to capture an ability to kind of send a signal to payers and others. Rather than having A, let's just vote, or let's talk and maybe do a quick vote on whether we think it's significant enough to mention a potential other benefit that certainly the fact that you cannot drive, you're not supposed to drive after taking lasmiditan, will be an important factor in viewing the broader value to clinicians and to patients. And B would be that Gepants may offer a unique vision of a safety profile that will sway clinical thinking, something like that. So if you think that these are strong, important potential other benefits for payers and others to think about, A is the dizziness and inability to drive is kind of a distinct feature within the profile, and B is a safety profile that stands out in the clinical field. Some people right now might want to make a quick argument for why you wouldn't want to say yes to either of those, that they should not be important potential other benefits. Anybody? Okay, why don't you go ahead and vote then, please, A and or B. A is the dizziness and can't drive. B is the distinctive safety profile. And when you're done, look up at me. Eric, have you voted? Yes, okay. 9 for the can't drive, dizziness, and an even split. So there you go, an even split for the second one. Okay, so noted, and will be in our report. Okay, with some difficult juggling of our time, I still want to spend most of the time that's left. We're going to have to go past 2:15, but I really don't want to not have a break, and I want to not do give short shrift to the policy roundtable. So we're going to try to go quickly through the contextual considerations, partly because I think we've heard excellent testimony from patients and representatives of patients and from clinical experts on these factors. This, again, you're going to vote on all that apply. This intervention, and the first one is Gepants. In considering its long-term value for money, what contextual issues should be taken into important consideration? A, this intervention is intended for the care of individuals with a condition of particularly high severity in terms of its impact on the length of life and or the quality of life. B, this intervention is intended for the care of individuals with a condition that represents a particularly high lifetime burden of illness. C, this intervention is the first to offer any improvement for patients with this condition. D, there is significant uncertainty about the long-term risk of serious side effects of this intervention. E, there is significant uncertainty about the magnitude or durability of the long-term benefits of this intervention. D and E always raise questions because we always know that there is uncertainty at launch. It's meant to capture whether there is particularly unusually high levels of uncertainty about important long-term risks or long-term durability of benefits. Any quick questions? We're going to try to be quick. Eric?
So just one clarification. I think all
Yes.
the questions in this set apply to the definition of the diagnosis of migraine who've not been affected.
That's right. I'm sorry. This is the same population.
Same population.
Right.
another point of clarification, that it really reflects acute migraine, right, and not chronic migraine or retractable migraine. Is that, help me put that in context, because I think we've heard some nice patient testimonies today of cases that were not quite the patient that might have been in a trial that we are evaluating today, if I understand it correctly.
Well, so go ahead, Steve.
Yeah, so as a point of clarification to the very moving patient sentiments that were expressed earlier, all of the trials that we presented evidence for excluded patients with chronic migraines. So we actually don't, it just hasn't been studied whether these medicines will be effective for managing those individuals. And in the trials, that was a definition of more than, I believe it was 15 migraine days per month. So that's just a point of clarification.
Thank you very much.
Okay. Rachel?
So usually when we are asking questions about E, we are usually asking a question about uncertainty about whether the benefits of a treatment will persist over time. But here there's actually a little bit of an argument in the opposite direction in terms of what we heard about the scenario analysis with potential increased benefits at 8 hours that we were unable to determine because of the use of the rescue medications and things like that. So I think it's there's a different valence to E in this set of drugs than we usually consider, and I just wanted to
Here I would probably, I mean, it's kind of fun to consider 8-hour long-term benefits, but...
Well, I think to the extent that we're explicitly excluding chronic patients and we're only talking about acute patients, it's a little bit challenging to consider long-term at all and what that
chronic
means.
just means you have acute migraine every other day of the month or more. I mean, it's a frequency more than...
I'm choosing to explain my own reasons for voting yes.
But what I would encourage you to do, we are going to talk, when we get to the long-term value for money question, we're going to talk about the base case and the 8-hour data. So that will factor in. This really is more like, you know, is there something, you know, this is already only a 2-year model for a variety of reasons, but is this a big consideration here? I mean, we know that we've looked at some treatments before where the huge issue around value, we had a one-time treatment, and if it lasts a lifetime, it's a great value, but if it wears off after 5 years, it's a terrible value for money. So it's kind of, in what context are we thinking here? Is this a particular situation where the long-term benefits are really a critical piece of the judgment around value? Okay, please go ahead and vote on, oh, sorry, Bijan, go ahead. All right, then we have to try to be really quick.
So when we talk about value for money, it's just there's this underlying assumption that we know the money, like the money that we'll be putting in there, right? But we don't know the prices for Gepants yet.
Right.
So how do you sort of go about it?
Well, actually, we do have the list price for one of the Gepants, but we're going to talk about the long-term for value. That's the next vote. These are the contextual considerations that should be in some way factored in to that ultimate vote. Okay, please go ahead and vote. And this one, again, it's any of the above, all of the above, I should say, sorry. Please vote for A, B, C, D, and or E. We're going to do the same one for lasmiditan in just a second, and that one's going to be even quicker, and then we'll get to the value vote. So I'll need to look at you when you're done and looking up at me. Okay, Reem, you're done. Bijan is done. Everybody's done. Okay. Okay, 9 out of 12, high severity. 11 out of 12, high burden of illness lifetime. 4, first ever, 4, significant uncertainty about the risks. 8, significant uncertainty about the long-term or magnitude of the longer-term benefits. All right, these will be captured now. Again, it should probably be a similar set of considerations for you when you think about this for lasmiditan, because these are contextual issues, not really related to its effectiveness or even its more, you know, I guess the uncertainty is related to its data compared to the Gepants. But I'm not sure there's going to be any particularly different question about the context here. I'm sure.
In looking at the responses to the previous one, I wonder about the interpretation of C. So the intervention is the first to offer any improvements for patients with this condition, assuming that we're talking about the population who are ineligible for or who have failed triptans, in which case that is a factual statement. This is not the first treatment for people with migraine, but it is the first time that we have an option for people with migraine who fit those criteria.
Rachel?
Just to clarify, though, we are today considering actually drugs with two different mechanisms of action. So to the extent that is one of them first or
Yeah.
both of them first? So
I tell you what.
That's irrelevant.
They come in close enough. The Kentucky Derby, someone would be declared the victor, but I think your point was, well, I was going too quickly perhaps, because the way that the patient population is sculpted here, you could say that, for the end-stage patient with nothing else, we have opioids. There's always been something to use. But we're trying to capture this basic idea that this has been an unmet need for some time, with triptans being out there for a long time, and having two new mechanisms of action in near time here does represent an important kind of first-time option for many patients who've lived with triptans for decades and not had really any other new effective options. So I think we'll go back and fudge your votes on the first one. Okay, let's vote on this one then, please. A, B, C, D, and or E. So staff, please note, we're going to change that vote on the previous question. Okay, everybody's done. 10, 11, still only 7. We're going to make it 12, you guys. For C, D, and E. So essentially the same votes on both. Not surprising, given the contextual aspects. Okay, so now, the one which you've all been waiting for. We only have a price on one of the drugs. So in our iteration that we will be doing with our new methods for reports later this year even, we'll be kind of changing this voting structure. But right now, we're only going to vote on the drug for which we do have an available price. We used placeholder prices in the model. But we're going to be voting on the long-term value of money with rimegapant. What did I think we had?
But that's not the one that we have a price for.
It should be ubrogapant. Okay? Sorry about that, folks. So that question should be ubrogapant. And we're going to talk about what its price is, and we're going to revisit the cost-effectiveness model. We're going to spend a few minutes doing this, and then we'll figure out what we'll do with the break. So we're still in the population of patients for whom triptans have not proved effective, are not tolerated, or are contraindicated. Is it the next question? All right. All right, I'll just change it to this one. Okay. Whoever voted already, wait, hold off. Wait till we hear the testimony and discussion. So, same thing. Patients for whom triptans have not been effective can't take them, not indicated. Given everything you've heard now about the comparative clinical effectiveness data, the potential other benefits and contextual issues, the incremental cost effectiveness, which we'll go over in a second, we're going to ask you to vote what the long-term value for money of treatment is with ubrogapant versus no treatment at the price that we are estimating, which is 27% discount from the wholesale acquisition cost. So, I'm going to ask Dan to remind us what the findings of the model were in the base case, and then I want to talk about the changes with the scenario analysis with the 8-hour data. We'll go back and forth on that a little bit, and then bring others in. So can you start us off by just reminding people about the basics of the model findings?
All right. So this information is contained in Table 14 for the base case and in Table 15. What we saw was, based on how we modeled it, we saw usual care costing about $10,000 and ubrogapant costing about $13,000 over the 2-year period. With regards to QALYs, we see 1.8142 for usual care and 1.8221, so about a 0.008 QALY gain. When we look at the cost effectiveness, we see value of about $379,000 per QALY gained in the base case. Do we want to talk about, do you want me to discuss the scenario analysis?
Well, let's do a pro-con, okay? There were reasons that we kept the base case the way it was, and there are reasons that some people will want to weigh in their own thinking about the sensitivity analysis. Let's give them that in as succinct a fashion as we can. Arguments for keeping it this way, or maybe we should go it the other way around. Let's hear the argument for doing it with the 8-hour data factored in first, and then the con to that.
Sure, absolutely. And so there is evidence that there may be a delayed onset of action with ubrogepant and possibly rimegepant as well. There's publications indicating that. In those studies, even though they used a double randomization procedure, they randomized people at the beginning, they randomized people at 2 hours, and we looked at those who received ubrogepant and then were randomized to placebo versus placebo receiving placebo. And we saw a similar effect over time, which even though there was a lot of patients who were not evaluated at the second time point, which was at 4 hours, 2 hours after the 2 hour second dose that patients received, which was placebo. We felt that, we thought that this is likely a true effect, that there is some improving outcome over time. The reason we kept this as a scenario analysis and did not make it the main analysis is because we were not confident that the effect size that we were seeing was a reliable estimate of the effect size because of the number of patients who dropped out of being evaluated the second time. It was only people who received a second dose of the drug. So all those who got benefit from the first dose were not looking for a second dose. And then there were other considerations there as to why or why not patients might take a second dose. And so we're not certain the effect size is accurate. We used our best, what we believe is a best estimate for the effect size in the scenario analysis. We believe the likely cost effectiveness of the treatment is probably somewhere between the scenario analysis and the base case. And we don't know where it would fall in that continuum. The base case relies extremely heavily on 2 hour time points. So there's limitations there as well. There are limitations.
David, you thought long and hard about this too. Steve, I'll invite you in if you want. And we can't have too extended a conversation, I'm afraid, but just given how central this is to the considerations around the long-term value vote, any other perspectives you'd want to share as CEPAC tries to wrestle with this question?
I guess the main thing I'd say is that the manufacturer argued prior to the additional analyses that we asked for that we were missing additional benefit above placebo between 2 hours and 8 hours. And they made that argument based on data that had a lot of problems in terms of confounding, censoring, things that happened. And so we weren't sure what to do with that. And we kept coming back to them with ways to try to look at the data cleanly. And what I think we can say is, not that this perfectly answers the question of the magnitude of benefit, because real patients in the real world will make decisions to take another drug or do something different. But looking at what happened in the clean data, there is no question but that patients who get ubrogepant at 4 hours, who didn't get benefit at 2 hours, are getting additional separation from placebo at 4 hours. That as you look at the randomized data, there is a real greater response to having gotten ubrogepant at time 0 than having gotten placebo at time 0. So we're sure of that. We don't perfectly know what that means for how to interpret the cost effectiveness.
So CEPAC, you're going to figure this out. No, it's not. It's for a year's, basically. You can think of it as for a year's practice. Yes, Bijan.
Yeah, I have a quick question. So table 15, the comparison is usual care. Usual care is not no care. So I guess the question is saying, or rather, no treatment. So to me, usual care is like over-the-counter medication. So is it just a typo, or is that's what we are supposed to mean?
It's just making it clear that it's not in comparison to triptans or anything else specific, but it would be their usual care of themselves thereafter. And the model, I'm sure, had background therapies as part of the cost, at least, on usual care from the trials.
It was based on the placebo of clinical.
In which other things were included, though. But again, when you're dealing with 2 and 8 hours, you're not too worried about other treatments they're going to use, except Well, that's part of the messiness, and that's part of the difficulty is, what do you do with data after patients can take other treatments? It's hard to know what benefits you're getting from the initial treatment given or redosed versus the other kind of added-in treatments. It becomes very difficult, and it's not something that the companies could snap their fingers and make a better study. Okay, so just to reframe again the incremental cost effectiveness findings, if you are a believer in staying what I would call conservative with the data at 2 hours, the cost effectiveness ratio for ubrogepant is what per quality?
379.
379,000. If you accept the 8-hour increase in effectiveness,
Those results are not in this, but it was 40,000.
40,000 per quality. Okay?
14,000?
That's the difference. And again, in long-term value for money also, what's that?
40.
40,000 per quality. All right? And I have been hesitant, and I guess I shouldn't have even said it the first time, I'm not going to call these conservative and optimistic. It really is it's a judgment about how you want to treat the evidence given some of the uncertainty around what we are doing with 8 hours. But on the other hand, you can call that too pessimistic if you want to.
But
Eric.
the standard for the 2 hour is driven by the FDA, right? I mean, there's a expectation that was set at some point in time by, I'm going to trust some very thoughtful and people that thought that the standard should be achievement within a 2 hour window.
I'll give the short answer, and the patients probably have been squirming through this, and they're trying to come up with the cleanest signal of benefit they can, and that's why the shorter time, because again, patients start to give up on the treatment they've had and they need something else, and once they start doing that, it gets harder to read the signal of effectiveness of the new treatment. So I'm sure the FDA said we need your shortest outcome as the prime point that we're going to use to judge whether you are better than nothing, but patients care both about quickness and sustainability. So there are data on what happens later out. It just does get, in a sense, confounded with what is going on in the background of patients' care. So we've tried to do the best we can to work with the company to even, I think, come up with some new ways to look at that could answer some of those perspectives. All right, incremental cost effectiveness is a piece of your thinking, right? Your relative certainty around the comparative clinical effectiveness is piece. The potential other benefits and contextual issues. The incremental cost effectiveness ratio ranges from, 380, 30, 50?
380.
380 to 40. Okay? And we're going to ask you to vote because the signal gets sent in a variety of different ways. And again, these votes don't get plugged and played in any insurance policy. These are, again, we're going to highlight the two different approaches and the two different answers that you get because that's what we want other people to continue to wrestle with.
Can we vote twice? I mean,
we can split our votes. Do you want to do that?
Just on those?
No. All right, let's take a vote. You're ready, I can tell.
Early and often.
Okay. Please make your vote. 2 other people have voted. Okay, this is going to be really interesting. Ready?
No.
It's popcorn. No. All right, you need to change your vote.
I'm seriously conflicted. I mean,
Go ahead, let's talk about that.
I'm seriously conflicted because I think we'll be giving a signal.
Can you pull it just a tiny bit closer?
Yep. I think we'll be giving a signal if we vote. I mean, $40,000 is, as we all know, like unheard of. So it's like we'll be giving a signal of like the price you have set is phenomenal and keep it. I think if we vote high, but we're just not certain about that. And so I'm more inclined to vote, say, with an intermediate, because I think it's clearly there is an outcome there that is working and it has an effect. But I would still say the price is set high because $350,000 is a high incremental cost effectiveness. And so therefore I'm like, if this is real and we're sure of it, then I'm all for it is of high value, but we just don't know that. And we'll be giving a signal of, even without knowing that, you should do nothing to lower this price. In fact, you could raise it.
Well, this is one of the reasons I know we're not going to have a unanimous vote on this one. And it's because I've sat in other groups around the country and internationally, and some people will say, I feel that we need more certainty before spending money where it could be wasted. So therefore, I'm going to pick the more conservative approach to the model, and I'm going to look for a lower cost effectiveness ratio, whatever. Other people will view this again. They may say that the potential other benefits, which weren't really even part of this, but now I'm being asked to vote about value, that will push me in a different direction. So this is where it's a judgment of how you deal with the uncertainty. It's always uncomfortable when a major single point of uncertainty creates two very different cost effectiveness findings. But it's helpful. It actually sends the right signal. It really depends on whether this drug does last longer or not. And so that's why we're wrestling with the question.
But doesn't this also underscore how absolutely important it is to articulate the questions? I mean, we've got sub-questions within a question, and they're confounding and they're sending a signal. So I just think that's an overall comment that the questions need to be as clear as possible.
Okay, Katie, did you have something to add?
Yes, actually, I guess I do want to ask a question, first of all. I mean,
Sure.
Triptans came out, and does anybody know or remember what the annual or just even a per pill cost was when triptans came out in the 90s? And obviously, we got to figure out inflation. But.
Jeff probably does.
So I do remember the cost when they came out because it was outrageous. I mean, I could not believe they were charging $10 a pill. It was just unbelievable. $10 a pill. Can you believe that? And so, we were really reluctant. Do we use this? I mean, what's the alternative? And we ended up getting there, but that's about what it was. I don't know what that comes out to annualize. You could probably do the math, but I remember because I was just appalled. Now, I was also appalled that when MS drugs came out, they were $12,000 a year. And I just thought that was appalling. And now they're up to 80, and we're talking, I think 85 a pill or something. But that actually is the number that came out. And back in the day, that was really outrageous. Now, there is inflation, but I don't think there's quite that much inflation.
Is the price that we know for Ibrogepant on a per pill basis? I think I know what it is. I don't know if we're allowed to say it at all.
All I know is the total drug cost per year here
okay.
is $3,570. That's assuming a 27% discount off the list price.
Okay.
And the use that was, obviously, some patients would use it more than others.
Great. Okay. 62. Okay. So I would just, I was curious. Thank you for that information. That patients currently save their medication. Acute rescue medications are supposed to be used when you feel an attack coming on. They're going to be the most effective triptans, even DHE. But insurance limitations or other issues, people may only get six pills per month. And I honestly think we're still paying, with insurance, many people are paying way more than $10 per pill. Be paying $25 per pill, and maybe that's inflated, but because they cost so much per pill, because they don't know if they're going to have 6 attacks this month or 17 attacks this month, and they need to take it as soon as possible, but they're like, maybe I'm going to have a worse one. So having something that obviously I think for me it's worth more to have access. I think it is more triptans don't work for me. Lots of other things don't work for me, and I'm not the only one. And valuing it out at $40,000 honestly feels like, and I know this is nobody's intent, but as a patient, it feels like my life or my quality of life is only worth $40,000 a year.
Actually, the way that the math works here, $40,000 per quality is one of the best, most highly cost-effective drugs we've ever looked at.
40,000 is great.
40,000 is great. Right. The lower the number you get there, the better. So this is where In a sense, if that's the view of the value in terms of the cost effectiveness arm that you're in, you're already in what we often deem as high value without even asking any other questions about potential other benefits, et cetera.
Okay.
So we need to move on so we can have the talk about quantity limits, coverage barriers, other things, okay? Step therapy and pricing. So let's go ahead and take the vote. I think if everybody's had the chance now to make their final vote, because you can always change it. But I still see 12 votes up there, and the results are 4 high value and 8 intermediate value. Oh, I'm sorry.
4 low value.
Oh, low, sorry. 4 low and 8 intermediate. Gosh, even I had read that incorrectly, so I want to make sure. Did everybody read the voting options correctly? Okay, I want to make sure that nobody made a mistake. Okay, 4 low, 8 intermediate. And I think that reflects the richness of the discussion around the uncertainty of the cost effectiveness modeling, the potential other benefits and contextual issues. And we are going to take a short break to come back to talk about how we're now going to work together moving forward with pricing, insurance, patients, doctors, and the real world. Let us please, because we are running behind, let's take a 10-minute break and reconvene at 2:45. 2:45 sharp.